Welcome to this webinar about cardiopulmonary exercise testing, part 2 as a masterclass, and now it's about the interpretation of cardiopulmonary exercise test results. The first webinar by Professor Stringer was more about how to get the most exact, the best data out of a cardiopulmonary exercise test. And thank you again for attending. So I assume most of you will attend for the second time. And I'm happy that I can introduce again this key speaker, Professor Stringer, for the second time for a webinar sponsored by Fire Medical. My name is Herman Groepenhoff. I'm the senior clinical advisor within Fire with a clinical background. And speaking about the last time, we could not manage to answer all your questions within even 20 minutes. But I think the good news is we're expecting again a lot of questions at the end, and you should ask your questions by our box, questions and answer box. And we try to, or we know already, we will plan a third webinar just dedicated to answer all your questions, also with Professor Stringer. Not taking too much time, maybe I already did. I'm happy to give over the word and the microphone to Professor Stringer.
All right, thank you, Herman. Very kind introduction. So we're going to talk, as I mentioned, primarily about interpretation today, but if you have questions, put them in the chat box and we will try to answer some at the end of this. And then we will probably have a third session sometime in June that will actually go over some of the other questions just to make sure we adequately address them. That's Herman, that's my disclaimer. My name is William Stringer. I'm a professor of medicine at David Geffen School of Medicine, UCLA. My interest is in respiratory physiology, primarily exercise physiology. And in terms of disclosures, we do have a book that's involved with cardiopulmonary exercise testing, and I'll be showing some of the slides from that. That's all that. So hopefully most of you that attended the last meeting got the message that even during the test, it's very important to actually be looking at the data. So I just wondered if anybody could put in the chat box what they think is wrong with this test. So you have oxygen uptake and CO2 output as a function of time here. The green is work rate. And then on the top, you have heart rate and ventilation. So I don't know if we can see the chat box. If anybody has any specific answers, I won't spend too long on this. But this is something that the technician should have fixed during the test. So that's why I show it. So right here, you can see there's a huge drop in oxygen uptake and CO2 output, despite the fact that the work rate's increasing. So something's wrong. There's a second issue right here at the end of the test. So it's important to go back up here and see that the ventilation actually drops dramatically. And that means that there was a leak during the study. And there's another leak right here. And so that really explains the issues with oxygen uptake and CO2 output. And again, should have been corrected during the test. I'm a fan of mouthpieces because they're less likely to leak, but even masks need to be checked to make sure that you're not losing gas exchange and your numbers are not incorrect. So that's just a little quiz from last time. I'm going to go on here. So I think if you want to read one paper in exercise physiology, it's really this classic paper that was done by Dr. Wasserman and Van Kessel and Burton back in 1967. And almost every important concept in respiratory physiology is in there, including the first drawing of the gears, which I'm showing you here. So I think we all owe a great debt to Dr. Wasserman. He really was the grandfather of this entire area of exercise physiology and using gas exchange to understand what's going on in the muscles. So one paper, it's big, it's 14 pages, 3 tables, 21 figures, which of course nobody would publish today, but they were able to do it in 1967. So the first thing I think in interpretation really is looking at the peak oxygen uptake. And so this is actually a diagram that comes from Roell's book on cardiovascular control. And so the axis here is all oxygen uptake between 0 and 6. So remember that. The axis is not time, it's not work rate, it's oxygen uptake. But let's start up here. So cardiac output goes up about 6 liters for every liter of oxygen uptake. So oxygen uptake and cardiac output are linked through the stroke volume, and the AV difference, as well as the heart rate. So these are the components of what makes up cardiac output. And you can see somebody with heart disease, this is mitral stenosis, this is a normal person, an athlete, go up very high in cardiac output, but also very high in oxygen uptake. So if you look at heart rate between those three groups, there really is not much difference. The heart rate ranges between about 60 and 200 in most people. And so heart rate is really not the differentiating difference in that cardiac output. It's really stroke volume. So stroke volume here in people with heart disease, normal, and athletes can go from a very low number, which requires a very high heart rate and eventually results in a very low oxygen uptake, very low cardiac output, to somebody that's an athlete that has very high stroke volumes and very high oxygen uptakes. And finally, the AV difference here is related to the type of exercise. And there's a slight increase, at least in this drawing, of the AV difference for somebody that has heart disease versus athletes. I'm not quite sure that that's actually true, but it's an important thing to remember that somebody with heart disease and limited cardiac output is going to be relying on AV difference. So remember, oxygen uptake is cardiac output times AVO2 content difference, and cardiac output stroke volume times heart rate. So this actually is a really important figure to have in your brain when you're thinking about cardiopulmonary exercise testing. So one of the other things to think about is to use the right terminology. So I think during clinical exercise testing, you should always be talking about peak oxygen uptake. So that's the maximum that you measured during the test, but it doesn't mean it's a true maximal oxygen uptake. So peak oxygen uptake is the measured value during the test. But if you want a true oxygen uptake, you have to go through a bunch of different constant work rates to see if that oxygen uptake comes to the same value. So what they've got here is they start out with a below AT, 100, 150, 200 watts, and these is constant work rate exercise. And then when they get up to 250, 300, 350, 400, you can see the exercise time shortens, but the peak oxygen uptake is the same across all of those. So that's a true oxygen uptake maximum rather than a peak oxygen uptake. So I'm gonna use the word peak oxygen uptake, and that's what I mean. There's never any guarantee that you actually have a true maximum during a test for a variety of reasons, and we'll talk about that a little more later. But one way to do that is actually to do your rest and loaded cycling all the way up to peak exercise and recovery, and then to actually have them go up to 90% of that peak value and continue for as long as they can do it. And what that gives you is an oxygen uptake that goes up to the peak value, gets a few minutes of recovery, and then goes back up to that value. You can see that those two numbers don't change, as opposed to the bottom one down here. When you go up to that second test, you can see that it actually goes up. So this would really be a true maximal oxygen uptake. This would be something where the peak oxygen uptake wasn't a true maximal oxygen uptake. So it's a little bit of terminology. It's a little bit confusing, but peak oxygen uptake is what you measure during your test. You're never absolutely guaranteed that that's the max. And of course, the amount of oxygen uptake is dependent on the type of ergometer. So bicycle versus treadmill, you're going to get higher numbers on a treadmill than a bike. So the oxygen uptake depends on the ergometer as well. This happens to be a bike. Okay, so does the rate of increase in the work rate make a difference? So let's say I set a person on a bike and I do 20 watts, 30 watts, or 50 watts. Of course, we don't usually do 50 watts. That would have to be somebody very athletic. But you can see the heart rate maximum is slightly different, but not much. But the peak oxygen uptake is essentially identical. The AT is identical too. So the peak oxygen uptake and the AT are not dependent on work rate increase. But what I'm going to show you is that CO2 output and R are dependent on that. So this is a fast, medium, and slow ramp. This is oxygen uptake. This is RAR. This is the actual diagram here. And so the fast ramp, say 50 watts, results in a rapid increase to peak oxygen uptake, as opposed to something like a 20 watt or a 30 watt, something like that. And this happens to be a patient. So this might be 15 watts, 10 watts, and 5 watts, for instance, but it's scaled appropriately. What you can see is that it actually reaches the same number despite differences in the work rate protocol. as long as you stay with the same ergometer. But what you see is if you actually do a very fast ramp, you get a lot of CO2 output, as opposed to a slower ramp where it comes out over a much longer period of time. So the volume of CO2 that's evolved from bicarbonate buffering of lactate is distributed across a longer period of time, and that's going to affect your R. And this is part of the reason that R is not a great way to stop an exercise test, because I could have an R of 1.3, I could have an R of 1.05 here, and which one is the one that I stop the test for? So you always want to actually have the patient persist until they can't keep their cadence above about 50, as long as they're safe. There's not other issues with EKG or saturation or other things, which you might stop the test for. Okay, so this is a standard 9-panel, and I'm not saying this is the gold standard, but whatever you do, you have to get used to what the data looks like in a standard format. So make sure that your lab produces a set of graphs that you're sure you understand where everything is. So for instance, this particular montage has oxygen uptake and CO2 output as a function of time here. It has O2 pulse and heart rate as a function of time. And then it has CO2 output and oxygen uptake so that we can actually pick an anaerobic threshold, and that's the heart rate. So these are all cardiovascular variables, and I think that's not a bad idea to group those so you can see them. This is the ventilatory variables. This is ventilation as a function of time, ventilation is a function of CO2 output, and tidal volume is a function of ventilation. So those are all important respiratory variables that we're going to assess during the test. And finally, you have gas exchange. You have the amount of ventilation required to eliminate a liter of CO2 or O2, the ventilatory equivalents. You have the end tidals of O2, CO2, and your saturation, and you have your R value starting down here around 0.9 or so and going up during exercise. So this is the beauty of a cardiopulmonary exercise test, is you have assessments of multiple organ systems during the same test and looking at the interaction of those. So that's important. And I'm going to get back to why I put these first three in a vertical format in just a minute. Okay, so what do you get from the 9-panel? You get maximum work capacity, which is peak oxygen uptake and work rate. You get an idea of what's going on in terms of the cardiovascular system, the O2 pulse and the heart rate reserve. The mechanical ventilatory limitations are showing up in breathing reserve, and the actual contour of tidal volume as a function of ventilation. You'll be looking at the lactic acidosis threshold to look to see if there's actually an oxygen delivery problem. And then you're looking for high and low VAQ. So high VAQ means a lot of ventilation relative to perfusion, and that's seen in heart failure, pulmonary hypertension, those kind of things. The VWT is a good marker of that if you have an invasive test, as well as the arterial minus end tidal, or you can use transcutaneous, which I'm going to show you a little bit later. And then the ventilatory equivalent would be very high, so a lot of ventilation relative to a liter of CO2 output. Low VAQ means that there's shunting going on, and that usually presents in a large AA difference during exercise. So there's a lot of information that's on there, depending on what's invasive or non-invasive, and you want to put it in a format that you can actually understand. Okay, so first thing was peak oxygen uptake. We got that now. Now we're going to look at the what I'm going to call the anaerobic threshold during this, but any of these work: anaerobic threshold, gas exchange anaerobic threshold, the gas exchange lactic acidosis threshold, the lactate threshold, etc. And VT1 is what's used in a lot of software programs. So VT1 would be what I would call the anaerobic threshold. So how do you pick that? Well, there's just basically 3 steps to that. And the first step is panel 3, which I just showed you, where is CO2 output as a function of oxygen uptake. You want to make sure that these 2 axes are exactly equal to each other in terms of size, so that a 45-degree line would just bifurcate this entire graph. And you're going to bring that 45-degree line up and see where the CO2 output begins to exceed oxygen uptake. And that's your anaerobic threshold. So that's a way to pick it. This would be the way that Dr. Wasserman would pick it. It's called the V-slope method, and that's very important for picking an AT. But the way that Dr. Whip would actually pick this would be step number 2 here. And that's taking that oxygen uptake, which is about 1.2 liters here, and going down and looking at the ventilatory equivalents and the ventilatory equivalent for oxygen should be going up at the time that CO2 is decreasing or stable. So you can see that's when it starts to go up. And you can see that the end tidal oxygen begins to go up at that particular moment. So this is gas exchange confirmation that this V slope is correct. And finally, the step 3 is looking at the RER value. So the RER value should be less than 1 at the time you pick the AT. If it's above 1, then you're past the AT. So I'm just going to show you that. This would be the first one where you pick the 45-degree angle, bring it up against here, pick that AT 1.2, come back to panels 1, 4, and 7, and verify that the ventilatory equivalent for oxygen is going up at the time that CO2 is stable or decreasing. And that's where the end tidal oxygen starts to go up. Those are all physiologic ramifications of an anaerobic threshold, additional CO2 output, bicarbonate bufferating lactate, and evidence that lactate is being produced during exercise. So finally, and this is important, an R of 1 is not the AT. The AT is back here. So the AT is when it starts up towards 1, not when it gets there. So your R during exercise is about 9 or 9.5, or 0.95, sorry. But in order to get over 1, you have to have additional CO2 relative to O2. So what happens is, as you start to buffer lactate, that's free CO2 comes out in your gas exchange. So you want to look and see where you pick this on the AT and make sure that it's below 1, which you can see it is. And that's where it starts up and continues up throughout the rest of the exercise test. Okay, so that's the AT, picking the AT, using gas exchange, using the arrangement of the panel 1, 4, and 7 to confirm it. And then you have sort of a Wasserman and a whip way to evaluate that. Okay, so we're going to actually switch to just a demonstration. It's very important to use the software, and the software allows you to manipulate this. So if you have an area where you've set up your computer to do evaluation, you can take the software and look at the particular test and then actually go over what's happened during the test. So this would be an example of what you'd be seeing during the test. You see the actual breath by breath here at the top. Whoops, don't go to one. Yeah, stay with results. You can see on this left figure, you have oxygen uptake, CO2 output. You have work rate here in green, and you have heart rate in, I guess it's sort of a purplish pink. And so that's actually a very important graph to be able to look at even during the test to make sure you're not getting leaks or other things that's affecting your results, as we talked about last time. So depending what kind of software you have on, this is obviously via software, but you want to go to this V21 here and take a look at what you've chosen. So what you can see if we just amplify that V slope down there, yep. You can see that this is the 45-degree angle. This is where it begins to separate. And so this is where you would manually place it if it hasn't done that itself. So you would sort of roll this blue one over. Yeah, so bring that up to there. And then bring that little manual thing over so you can see where it goes to. Yeah, bring that over. And then this will be something you can see on the other graphs, right? That little further over, a little further over. Okay, a little bit fit. That's good. Now you're going to look at where that is in terms of the end tidal. Does the end tidal oxygen start to go up when the CO2 is stable? Does the ventilatory equivalent for oxygen go up at the time the ventilatory equivalent for CO2? And this actually is a pretty good area of the AT. So you're going to use the software to actually verify what's going on, and it allows you to check what your technician and the computer will actually have picked something. I challenge you not to just agree with what it comes up with, but actually look at the graphs and make sure they make sense in terms of reassessing the V slope, reassessing the gas exchange ramifications of that V slope. So the other one would be the actual slopes themselves. So if you go with the slope 1 up here, what you've got is graphs of various things. So the first and most important one here is the VO2 work rate relationship. So that's this top left one here. So make that a little bit bigger so we can see it. what you can see is that this is a line looking at oxygen uptake as a function of work rate. And remember that if you remember one number from anything I've said today, it's about 10 mils per watt. So when you bring this up, you want to see if the data actually conforms to that. And usually what I do is I try to get away from the very peak and the very start, because the start has kinetic changes that are allowing the work rate to go up, but the gas exchange is slightly behind that. So I might go a little bit in from that and a little bit in on the other side. And you can see that the slope up here, put your, Herman, put your slope right, or put your arrow right on the slope so they can see it up there. It's at 9.9. Okay. So that's essentially 10. That's fine. And then the other one would be to look at the ventilation as a function of CO2 output. So that's this top right graph. Yep. So what you'll see here is VT1, which is the anaerobic threshold. VT2 we haven't talked a lot about, but that's the respiratory compensation point. And what you can see is that eventually ventilation goes from being linear to being curvilinear. And so if you graph the entire axis here, what you'll see is that the slope actually increases, it bends it up, okay? So that slope is 31.2, which is actually abnormal. But if you go back to that and constrain this to the VT2, which is what you should be doing, because that ventilatory threshold is what we call the respiratory compensation point. That's where you want to be doing it. And so the VEBCO2 is normal here. It's 22, sorry. So that's an important thing. So you want to be looking at these graphs to make sure that the technician or whoever's reading them for you has actually constrained these appropriately. So I know that's kind of a lot, but what the major point here is that you should be using your software when you have an interpretation center or computer to use this to actually pull it up, look at the actual study, and adjust it as needed. So, okay, so I think that's good. I'm going to go back to sharing the actual slides here. Here we are. Okay. So, I'm going to admit that I'm actually a pattern person. I'm a visual learner. And so I'm going to show you some stuff that comes from the Wasserman and Whip book. And I like the way it's actually put out, because I think as you're learning CPET, patterns of changes are very important. So I'm going to go over some of the telltale signs a little later. But being able to take, say, panel 1 and look at what you've got in the study in front of you versus these particular ones. So this is a group of normal in the top left, coronary artery disease, peripheral arterial disease. This is a cardiomyopathy, heart failure. This is pulmonary vascular disease, obesity, COPD, sarcoid, and interstitial lung disease. So this is a nice sort of sampling. It doesn't guarantee that whatever's in front of you actually matches up to one of these, but it actually starts you on sort of the right course. And so if you're a visual learner like I am, that's great. There are other ways to do this, which are what we call flowcharts. I'm not a big fan of flowcharts, but they are a good way to start when you start to do interpretation. But I like the visualness of this. And so you can take any of the panels and do the same thing. Well, before I leave that one, so this is a normal oxygen uptake, CO2 output, and this is a normal patient. Look at somebody that has pulmonary vascular disease. There's a very low oxygen uptake, about 1 liter, and lots of CO2 output. And the other thing would be something like obesity. This is a big jump in unloaded cycling. This is someone that has a large BMI and has a large increase, although the total number of oxygen uptake is actually pretty good. And then COPD down here, also a very low oxygen uptake. And this is the work rate relationship. And so you want to make sure that you take a look at this panel 1. I think it's one of the most important panels that you can start with. And then you go to the other panels and decide what's going on with them. So this is actually panel number 2, and it's O2 pulse and heart rate. And you can see normal O2 pulse, 15 in this patient, normal heart rate's up to about 180. This is a great study. But if you look at something like pulmonary vascular disease, you can see that the O2 pulse is very flat. It almost looks like a table. So there's a limiting process to moving blood through the lungs, and even despite a fairly high heart rate. As opposed to something like obesity, where the O2 pulse is actually very high. So this again gives you some patterns to look at during the test in the different panels, this panel too. So panel 4 is looking at ventilatory equivalents. Ventilatory equivalents should drop below 30 during an exercise test as long as the end tidal and the VWT are normal. Once the VWT and the end tidal are abnormal, you're going to see very high numbers. So for instance, in pulmonary vascular disease, very high ventilatory equivalents, COPD, et cetera. So this is not as good a differentiator as some of the others, but you'll be able to see the patterns and how that matches up with the study in front of you. This is panel 5. Sorry, it's jumping around. So this is ventilation as a function of time. You can see this is a very high ventilation, over 100 liters here in a normal. Again, obesity is a very high ventilation too. But things like peripheral arterial disease, where you might stop because there was cramp in the leg, you can see the ventilation gets up to very low numbers. And same thing with COPD and other things, IPF, the numbers are much lower than normal values. And then finally, gas exchange in terms of looking at the CO2 output relative to oxygen uptake is much different in different types of studies. Again, for something like peripheral arterial disease, where you actually stop because of pain in the extremity, the R value doesn't get up very high. In a normal study, you'll see it get up to 1.1, 1.2 pretty easily, depending on the ramp work rate, of course. So that's another way to look at it. And then finally, this is tidal volume as a function of ventilation. You're looking here to look for ventilatory limitation, sorry. So how close does their ventilation during exercise, this is tidal volume, this is ventilation, get to their MVV here? You can see that basically this bounces right up against it. This bounces right up against it too. So these are both ventilatory limited patients that have obviously pretty serious respiratory diseases, as opposed to most people that they're quite a far distance from their MVV at the end of exercise tests. So that would be the breathing reserve that we'd look at during exercise, and it would help us understand it. So this is a visual way to look at it. Of course, you're going to print out your data and take a look at that too. But it also, I think, gives you a montage to look at, so that when you see these things, it's almost like a fingerprint. You can see that this is this particular type of disease. And these are the manifestations in each one of the panels that indicate that disease. Okay, so one of the things you're going to have to deal with is what kind of normal values should you actually use? And there really isn't a great answer for this in my mind, and I'm speaking for myself, but you have to pick a normal values to get comparisons. So percent predicted, et cetera, peak oxygen uptake, work rate, ventilatory equivalents, et cetera. So you have to look at what's set up in your system and what equations they've actually done. And they'll have, if you go into the sort of the blood and guts of the software, it'll actually show you what the equations are, where they've got them from. You need to make sure that that's a population that mimics yours. Let's say the Friends database was collected on university campuses in young, pretty fit, athletic people. That's one of the questions we got is that a good comparison? And so let's say you're taking care of 60-year-old people that have heart and lung disease. That's not going to be a great thing to compare it to. We actually use a set of predictors that Wasserman and Whip created, Dr. Hansen as well, that mimics, I think, more patients than athletes. But if you're dealing with athletes, that won't be the right thing to pick. You'll want something like the Friends database or some of the other athletic databases. And we'll talk about that in the question and answer in the third portion of this, what to use in terms of those. But once you get a set of predicted values, you want to see how that actually matches up to your actual population. So you have the predicted values, you do some testing, and do they make sense? Do they actually seem to help you do the interpretation or not? Most predicted values actually have weight inside of them, but not all of them. And so I think as we get more obese as a society, it's important to make sure that there is a weight correction in there, because what happens is your heart and lung apparatus doesn't get any bigger, but your chassis does. So it's sort of like having a small car engine and a large trailer that you're pulling. So that's what goes on with obesity. So we frequently see that their numbers exceed predicted values, but their external work is abnormal, is less. And finally, you want predicted values for each one of these things if you can get them. I'm gonna say I don't have a complete answer for this. GLI, as they've attacked PF pulmonary function testing, they're now after trying to do the same thing for cardiopulmonary exercise testing and using data from a lot of different centers throughout the world. So we'll see how all that goes. But for now, what I tend to use is a peak oxygen uptake around 85% of predicted. If it's above that, then it's probably something that's okay. Anaerobic threshold more than 40%. But remember, as you get older, your peak oxygen uptake comes down, your AT stays about the same, which is about comfortable walking. So that ratio actually goes up. So somebody who's 70 years old and had a 40%, that would be abnormal. Somebody that was 40 years old, 40% would be fine. So it's important to correct the anaerobic threshold percent for the age, which can be done with certain equations. Breathing reserve, I like to see more than 15 liters, but some people use the percent of MVV above 80 or 85% of the total. So that means the ventilation during exercise compared to the MVV is higher. And finally, ventilatory equivalent for CO2, as long as the end tidal is okay, should be less than 30, 32. So those are kind of like 10,000 foot view. Once you pick a set of normal values, you want to see if there's, if you have somebody that's very healthy and they don't compare well to your normal values, that's going to be a problem. Same thing if you have somebody who's very sick and you'd use your predicted values, maybe that doesn't help you really understand their disease process. So normal values is not an easy discussion. Unfortunately, there's lots of predictors out there. But you can talk to the group as they're setting up your system. And it's a good idea to take a look and see what the actual predictors are. I like to actually put them in the report as well, what predictors I'm using. So anyway, I promise you I get some common pitfalls, and they're related to what we just talked about. Did you pick the AT and the peak oxygen uptake correctly? If you didn't do that, basically everything else is going to go awry past that. The wrong normal values for the population we just talked about. And so if you're getting a lot of abnormals in people that you think actually are fine, that's weird. And then if you have somebody that's got heart and lung disease, severe heart and lung disease, and they're exceeding predicted values, that's also going to trigger a little bit of an investigation. But the third thing is actually very important. And I actually recommend to have the provider in the room during the test. That's my recommendation, and I'll tell you why. First of all, for safety, because lots of things can happen during CPET. They don't happen very often, but arrhythmias, people getting lightheaded, et cetera, can happen. And I recommend to have a gurney around that you can lay somebody down because the ground's a little bit untidy. But having a gurney that you can rapidly get to, I strongly agree with. But also trying to make sure that the test is maximal. So the safety is the most important thing. The second thing is being able to see the actual study as it's unfolding. So if there's problems, you can actually use the interaction with the technician to make sure that those things are corrected. Just like that first slide I showed you, if I was standing in that room and there was a big drop in oxygen uptake, the first thing I'd look at is ventilation and make sure there isn't a big leak with the patient. So the submaximal effort is helped by having the provider in the room separate from the technician. So both of those actually are very helpful to make sure that you're not interpreting a submaximal test as a maximal test. So just imagine that somebody is normal. They're about halfway into their test. They're about to hit their AT and the lights go off. So, the computer shuts down. Let's say it saves the file, but you can't continue the test. And if you interpret that as a maximal test, you're going to have very low peak oxygen uptake. You're going to have no anaerobic threshold, and you're going to have all sorts of abnormalities that have nothing to do with the patient. It has everything to do with the lights going off or the patient stopped or whatever. So you also want to make sure that the technician writes down why they stopped at the end of exercise. I usually try to use a very open-ended question, at the end of exercise, why did you feel the need to stop? And then if they're not too descriptive with that, I'll get down into whether it was more breathing or legs or maybe orthopedic issues, et cetera, and document that so that later on you can actually dissect that. If you're not in the room, you want your technician to write more. If you're in the room, then you've got a good feeling for it. Anyway, so we're going to talk about exercise mechanisms of exercise limitation, and they can be almost anything here. I'm going to go through these in some detail, but obviously cardiac and ventilatory is something we think about, but a lot of the peripheral muscle and anemia, those kind of things are actually very important. So the cardiac mechanisms, we've already talked about oxygen uptakes, cardiac output times AV difference, cardiac output's heart rate times stroke volume. So when you see a low peak oxygen uptake, one of these or both of these are abnormal. So the content could be abnormal, meaning they're anemic, but it also could be a heart rate limitation, say they're on a beta blocker, or they've got an abnormality of stroke volume. Maybe it's a dilated cardiomyopathy or a preserved ejection fraction, heart failure, et cetera. The LAT is also helping you understand cardiac mechanisms, because cardiac disease should have a low peak oxygen uptake and should have a low anaerobic threshold. That's really what moves you into heart failure, and I'm going to show you that in a minute. And then remembering the O2 pulse is actually trying to look at the stroke volume times the AVO2 content difference. So getting heart rate out of that equation, how much oxygen per beat is being provided. And that can be an abnormality of stroke volume or AV difference or both if it's abnormal. So the ventilatory is the same as the cardiac output. It's tidal volume times respiratory rate. So you're going to be looking at both of those variables. Very high respiratory rates could mean that there's a change in lung compliance, a stiff lung. Looking at the end-tidal O2 CO2 and then the RER. If you're drawing blood during exercise, you may show that they've actually got chronic respiratory abnormalities, maybe a metabolic alkalosis or acidosis that may be affecting gas exchange, and of course hypoxemia. But most of this is done with just transcutaneous pulse oximetry now. Anemia, we've already talked about. When we actually have a setting on our request form about what's their most recent hemoglobin. And if they're in our system, we can look it up, but a lot of times they're referred from outside. So it's important to make sure that you're not interpreting a study as abnormal when it's really anemia. And carboxyhemoglobin is important for people that actually have, smoking, because it actually can affect basically percent by percent the peak oxygen uptake. Deconditioning is actually very common in our society. There isn't a lot of exercise that anybody does, but it affects both the mitochondrial function, density components. It also affects the capillary density, and it probably affects the peripheral distribution of blood flow. So all those are important, and all those respond to training. But the things you'd be looking for is a high heart rate, low stroke volume, early anaerobic threshold, and a low one, and low peak. So these are mild cardiovascular stuff versus actual cardiac disease. Those are very difficult to differentiate and sometimes require further either cardiac testing or to train somebody and see if these things actually improve. So what I'm going to do is talk a little bit about the peripheral muscles, because we don't think too much about cardiopulmonary exercise testing doing the periphery, but really your muscles are where this oxygen uptake, the majority of the increase in oxygen uptake is your muscles during exercise. So you're really assessing muscle function here, not only capillaries, mitochondria, but also the muscle capacity to generate ATP. And finally, motivation, and this is very important, I think, to be in the room as well, to see if somebody, they just sort of stop and there's no real reason and they don't have a reason. Maybe it's some kind of evaluation of their work fitness, et cetera. You want to be able to have an assessment of how much they actually tried during that study. And again, your technicians should be documenting that. And finally, of course, the real beauty of CPETs is you actually get a hold of different types of interactive limitations that actually come from different organ systems. So I'm going to talk about what I call the telltale signs. I'm going to go through these sort of 5 examples fairly quickly because we're coming down the road. But this is a graph of these 5 and these important variables and what's abnormal with these. And I'm going to go through these in detail, but this is a way to sort of, when you're looking at your study, you can use a figure like this and say, well, does mine fit into this particular group or not? And it doesn't say this is the end all be all, but it's another way to sort of use patterns to assess cardiopulmonary diagnoses. Okay, so telltale signs of pulmonary arterial hypertension on CPET. I'm going to show you what I think it is in terms of bullet points, and then I'm going to show you the actual graphs. But low peak oxygen uptake, flat O2 pulse as we saw before, high ventilatory equivalence. Sometimes you'll see right to left physiology, which we're not going to talk too much about today, but that's an interesting thing. And then obviously you'll see improvements in these with pulmonary vasodilators. So in terms of the pulmonary vascular disease, mentioned here, the peak oxygen uptake is low, a lot of CO2 output. The O2 pulse is flat, almost table-like, and high ventilatory equivalents. These are very high in the 60 range. Normal would be about 30. So this would have sort of telltale signs or fingerprints of pulmonary vascular disease. And again, you'd want to confirm that with your history. You've got information that comes in on the patient. You do a focused physical exam. Maybe you hear actually splitting the S2, something like that. But you're also going to put that together with your exercise test. Data, history and physical, and then the exercise test. You're going to use all of those, prior echo, whatever they've got. So you're not constrained just to the CPET, but the CPET is going to help enforce what we think is the leading cause and what we need to focus on in terms of limitations, so that patient actually gets benefit from that CPET. Okay, so heart failure, we already talked a little bit about low oxygen uptake, low peak oxygen uptake, low O2 pulse, and actually they have a low VO2 work rate. I'm going to show you that. And they can have high ventilatory equivalents. So low peak oxygen uptake, low AT up here, O2 pulse low, although it doesn't have the same contour as what we saw before. So again, if you're a visual learner, those two look different, pulmonary vascular versus cardiac, and the ventilatory equivalents are high. So this is going to be suggestive or a telltale kind of presentation, but it doesn't diagnose it. What you need to do is put that together with the other data that we just talked about. Okay, so obstructive lung disease, this isn't a great way to diagnose it because you're going to have PFTs anyway. So I don't restrain myself from looking at any data that comes in before the test, but you're going to see usually a very low peak oxygen uptake, frequently a low AT, high ventilatory equivalents, and low breathing reserve, which is very important. And that things like pulmonary rehabilitation, which I'm a strong advocate of, do actually improve their ability to do things, even though it doesn't change the PFTs. The training effect lowers the lactate, so their ventilatory ceiling isn't reached as early, and they can actually do more exercise. So please think about referring people to pulmonary rehabilitation, as it's a great way to improve obstructive lung diseases. Okay, so what you're going to see is a low peak oxygen uptake, and the O2 pulse is going to be low, although it is slowly increasing, high ventilatory equivalents. But the most important thing is you're going to see that their ventilation during exercise is a very high percentage of their MVV. So the ventilation relative to MVV will be above 85% predicted, or the MVV minus ventilation will be less than 15 liters. So that's another way to diagnose ventilatory limitation. Okay, so ILD, again, you're going to have imaging, PFTs, other things to look at, but they're going to have signs that are very similar to pulmonary vascular disease. And frequently they actually desaturate. And sometimes they have to actually be studied on high FiO2 because they're unable to do a CPET on room air. But what you'll see is very similar to what we saw before, low peak oxygen uptake. The VO2 work rate relationship is very abnormal. So the oxygen uptake is sort of flat here when the work rate's going up. O2 pulse is flat, table-like as well, high ventilatory equivalents, and they even go even higher during exercise. And again, for interstitial lung disease, you may see very high respiratory rates because the tidal volume is constrained. So in this particular one, this is 50 liters, and this is about 0.8. So this is a respiratory rate that's well above 50. And you can put the actual respiratory rate isoplex on their figure. Some of the softwares will do that. Obesity is, as I mentioned, very common, and sometimes it's very hard to separate what's going on. But they do have normal oxygen uptakes compared to predicted, as long as you don't correct for the weight. Once you correct for the weight, you're going to see it much lower. But we tend to actually put both values on our CPET reports. Mils of oxygen per kilo per minute, and then we just do an absolute number, which is liters per minute. And we put both of those on our report. AT is going to be normal. O2 pulse is high. Sometimes they do have a low breathing reserve. And the rest of the gas exchange looks fairly normal. And so we saw an example of this already with the unloaded cycling, a big jump in oxygen uptake. Normally, unloaded cycling should be about 500. This one, even at rest, is about 500 and goes up to about 2.5 liters. So normally, rest would be about 250 or 300. Unloaded cycling would be 500 to 600. and then go up during exercise. So you can actually even miss the anaerobic threshold in this transition in obese people. And that's why you want to start with sometimes a low cadence, like 20, 40, 60, and bring it up during the unloaded cycling. Very large O2 pulse, good heart rate response, normal ventilatory equivalence. Actually, this person is very close to their MVV as well. And sometimes you'll see that in athletes as well, that they get very close to their MVVs because they're highly motivated. So this would be very characteristic of obesity. And finally, long COVID is kind of the disease of our generation. Most of these people have sort of 90% are predicted in terms of their FEV1, their TLC, and their DLCO. So their PFTs may be slightly abnormal, but not enough to really affect the exercise test. A large percentage of them are deconditioned, but they can have obviously both central cardiovascular and peripheral oxygen extraction issues, but they rarely have ventilatory limitation. But a lot of these people have erratic breathing during exercise. So sometimes that's interesting, is their ventilation is going up and down, tidal volumes all over the place. That's somebody with sort of dissociative breathing. So this particular person, peak oxygen uptake is a little bit low here. The O2 pulse looks like it's actually reasonable, but it's still also a little bit low. So low peak oxygen uptake, low AT, ventilatory equivalence usually normal, and this is actually VDVT transcutaneously, and that number is actually pretty normal in this person. So the gas exchange is normal. So there's lots of that says heart failure up there, but it's not. It's actually meant to be long COVID. Okay, so these are the things I just sort of went through, obviously very quickly, but setting up a little figure like this or using something like this is very helpful. I think initially in your sort of quest to become a good interpreter. And later on, it probably is not going to be all that helpful to you. It's meant to be kind of training wheels to start with, as those 9-panel examples are. But once you get that under your belt, that's when you sort of move to the next level of understanding the complexity of different organ systems interacting. And these are really meant to be sort of unidimensional. You know, what if they just have heart failure? What if they just have COPD? And of course, patients come in with, 1, 2, 3 things of these, and maybe more. So you have to be able to dissect those out during the exercise test. Okay, so what you're going to do is you're going to transmit this information to your provider. So the first question is always, who sent you the referral? Are they sophisticated in exercise testing? Let's say they're a pulmonologist or a cardiologist that does this all the time. I think I'm probably going to, state what I think is going on, but not go into a lot of detail. If it's somebody that isn't normally understanding cardiopulmonary exercise testing, this last line I think is very important, what your impression is. But I'd like to put down, dissect that a little more. I use a general category where I talk about their work rate, their oxygen uptake, their LAT, and then a cardiovascular one that looks at peak heart rate reserve, O2 pulse, those kind of things. And then ventilatory, looking at for ventilatory limitation during exercise, and then gas exchange. And then importantly, CPET is really a good study to repeat over time. So you can actually come back to what the study was before, and this happens to be 3 studies a year apart in a particular person with pulmonary hypertension. And the data, as you can see, this patient actually gets a lot better once they were treated with pulmonary vascular dilators. Not only peak oxygen uptake going up, but LAT went up. This actually, I think this line's actually shifted. But in terms of the way that you can interpret those, you want to be able to compare things to prior data. So finally, the interpretation, that may be as far as anybody reads. I like to put specific recommendations in there. So this is a pulmonary hypertension provider that sends this to us, that uses cardiopulmonary exercise testing all the time to not only diagnose, but adjust medications. I don't need to go into a lot of detail, but they're fairly similar from a year ago, but they're much better than when they started. So, okay, so that's pretty much what I wanted to talk about. I'm happy to take any questions, and I can turn it back over to Herman if he wants to grab some questions. Or
no, very shortly. Thank you for this impressive overview of CPET interpretation in only a look at 55 minutes. So this is a big challenge, but I think you did a very good job. And
Thank
the
you.
good thing, we already have some questions. But again, half of June, please watch our website or LinkedIn. We will send the advertisement for this third webinar where we want to have the interactive questions and answer part covered. But we still have, I think, another 15 minutes, and I will read the questions we already have for you.
Sure.
So let's see what we already can do. So even though you find a plateau over a range of load in an incremental test, do you still use the wording peak VO2, or is it then a max VO2, VO2 max?
It's not a max for sure. Let's define plateau. So if the work rate continues to increase and the oxygen uptake plateaus, that may be a maximal oxygen uptake, but it needs to be much higher than the predicted values, or at least at the predicted values. Let's say it occurs at 50% of the predicted value. So when you're looking at the screen during a CPET, it'll actually show you what the predicted oxygen uptake is for that person. So if they're above that and they plateau, you're right, it may actually be a maximal oxygen uptake, but I still would describe it as the peak oxygen uptake. So that ergometer, that day, that person, that's what we got. And it may actually change some other day. But if it's low in relation to the predicted oxygen uptake, I'd be very careful that there's something else going on. Like that first slide I showed you, it showed the drop in oxygen uptake, which is related to a leak rather than something that's going on with the patient.
Okay, thank you. How do you interpret a test where the work rate doesn't increase by a ramp, but by a stepwise protocol? So the
Okay, so
constant load by only increasing each stage, but yeah, you understand.
So I think it's important to have a protocol that you get used to. You understand what the physiologic ramifications of that protocol are. Could be treadmill, could be bike, could be stepped, could be continuous. I like continuous, but steps can be interpreted. Really, you can get a max test out of a step test very easily. I think sometimes it's tough for the patients once it increments to the next level all at once, that they feel like, okay, I've just got to stop. That's too much. As opposed when it's gradually going up, you can give them a little bit more encouragement and see if you can get more of the test out of them. So I like continuous ramps, but if the steps are not too big, I think it's good. You can do it that way too. But all the commercial systems will set up no matter what you want. And, having a 5, 10, 15, 20, and maybe even a 30-watt ramp set up already so you know what to pick. And then the important thing, as sort of implied here, is you need to talk to that patient a little bit, see how active they are, and pick a work rate that's going to give you a test that lasts probably between 5 and 10 minutes. So that gives you enough data to interpret. If it's too steep a ramp, it's going to be a very short test, very hard to interpret. And if it's too slow a ramp, it's going to take forever for that patient to finish the test, and they're going to get bored, or the seats uncomfortable, or their mouths dry, and that's why they stopped. It had nothing to do with the actual physiologic limitation.
Okay. Are there specific variables that you recommend assessing to differentiate musculoskeletal impairment from cardiac or respiratory impairment? Probably in your table.
Yeah. So we don't do a lot of assessment of peripheral muscle strength during an exercise test. In fact, that's one of the things we're working on these days with several of our investigators, trying to what we call the muscle CPET, but actually using isokinetic assessments before and after the test. But there are other ways to do it, electrical stimulation, et cetera. That's not very easy for a patient to do. But what you're looking at in gas exchange is how the muscles are working. And then if the gas exchange is abnormal, then you have to figure out what was causing that to be abnormal. And that can even go down the road of muscle biopsy and assessing the different complex chains in the mitochondria, et cetera. So it depends a little bit on the history, a little bit of what's going on. And then deconditioning is so common that I would guess that a lot of these things are going to be related to deconditioning rather than true muscular abnormalities, muscular type deficiencies. So it's a good question. I think we need to improve our CPET characterization of the muscles. And that's being done in several labs right now. And I think that will be something that the people, the equipment makers will actually integrate over time. Requires a special bike. That's the problem.
Okay. Of course, I do not want to decide for you, but I see two questions. Can you clarify AT1 versus AT2? And if we use ventilatory measurements, can we truly determine AT, etc.? So I think I have the feeling this we will cover in the next webinar, because you said something about VT2 you will not touch in this webinar.
Yeah, well, I just briefly, AT1 is the anaerobic threshold. Is when your CO2 output goes up relative to your oxygen uptake on the V slope. You confirm that with the ventilatory equivalence and the end titles. VT2 is when the slope of ventilation versus CO2 becomes curvilinear. So normally your ventilation is going up proportionally to CO2 output, and then it goes up curvilinear. So VT2 should be when it goes from being linear to curvilinear. And that's what I call the respiratory compensation point. I actually don't like either VT2 or AT2, but that's what I've seen in a lot of software. So you got to be able to use sort of like multiple languages for the same thing.
Yeah, and also related to the VT1 or 2, the computer usually picks it for us, like in our software. Would you do this if it is inaccurately usually? So I also recognize that people like it to do it by themselves, and I also know some exercise professors, or at least one, who says, oh, it's maybe better to let the computer do it, because then you always do it in the same way.
Well,
it's a little question from my side. Sorry.
No, I think that's all good advice. I think you can, the computer will pick something. I think you should just evaluate that. Just like, you have a student in your class, you evaluate their performance. Is it good? Is it bad? And that's part of the reason I want you to go to the computer workstation, be able to pull up the data and look at it, because that allows you to change things if you don't like it. And that's a good time to talk to your technician and say, here's why I think it's something different, and educate them, bring up their level of CPET physiology understanding, and, really bond with that technician, because how they conduct that test, as kind of our first seminar, is so important, because the interpretation can be completely derailed by bad data.
Okay, is a VE-VCO2 slope normal till 30 or 35?
I think 35 is a little high. The easiest way to say about this is the higher it gets, the more likely it's abnormal. So let's say it's 35 versus 40 versus 45. By the time you get to 40 or 45, it's abnormal. 32 versus 35 is going to be very hard to tell if it's normal or abnormal. And this is why transcutaneous CO2 is very important. Because remember, the ventilatory equivalent is related to the arterial CO2 and the VDVT. So specifically, a low arterial CO2 increases the amount of ventilation required to eliminate a CO2. So you have to have more blood pumped through the lung, eliminate that CO2. A VDVT increases the amount of ventilation relative to that CO2, because the lung becomes inefficient. So both of those factors can actually affect the ventilatory equivalent. So 35 versus 32, you would probably have to have arterial blood or a transcutaneous to figure that out. But I would be suspicious that 35 is abnormal. 30 or 32 is very likely to be normal, and 35 is more likely to be abnormal, but it doesn't say that it is, because you have to know what the arterial CO2 is, and we use end tidal as a proxy, but that's a terrible proxy. I recommend that person either get a blood gas around their AT, or to use transcutaneous CO2 if you have that capacity in your lab.
Okay, thank you. We are on time, but I take some of your time even when we have the third webinar. I think it's good to continue for another 10 minutes, but then I show you that I will try to stop this. What do you prefer for the VE-VCO2 slope? I think you already said something about it. It's about the linear phase or over the whole range of the exercise. So do you prefer to take the slope 2 VT1 or 2 VT2?
Yes. So, so the slope should come up to VT2. That's the respiratory compensation point. And then you should actually do the whole curve. So we report both in our clinical studies and our clinical reports. research studies as well as clinical. So some investigators like the entire slope. Some investigators like just up to the respiratory compensation point, VT2. The slope will be increased by that curvilinear. So that's what you'd have to remember. I prefer it to cut it off at the respiratory compensation point and use that data. But that doesn't mean that other people feel the same way. So reporting both sort of keeps everybody happy when we're trying to do that. There's also some data that people either have respiratory compensation point or don't have poorer outcomes, meaning people with heart failure. Agostoni has done data trying to make sure that there is something going on with the respiratory compensation point. So the respiratory compensation point is actually very important. Guys. So sorry, intruders. So in terms of the respiratory compensation point is probably a good marker of outcome, at least in heart failure and maybe in other diseases. So I think it's important to know where it is. It's important to look at those two slopes, but it's also my recommendation would be to go up to the respiratory compensation point and use that number. So as long as you do the same thing each time, that's fine. You don't want to be comparing one study that did it one way to one study that did it the other way.
Okay, and then a little bit for myself. Then I assume you take other reference values, because the question was it below 30, 35? Do you
Yes.
take another reference or a cutoff value then?
Yeah, we may want to get back to this in the question and answer, because there's a slide
sorry.
I can show you that really helps to understand the ventilatory equivalent and what's solidly normal and what's solidly abnormal. And just like life, there's gray areas, and gray areas would be between 32, 35. Above 35 is more likely to be abnormal, but it's not guaranteed. And that's why you need to know the arterial CO2, and actually you need to know the V/VT.
Yeah. Then we switch to the other slope. If there is an abnormality, won't the VO2 work slope be below 10, even when you try to edit it? Like we of course we showed by our software that you can take another range, but
yeah. So I think that the issue would be where you constrain it at, because the initial part, the work rate starts up, oxygen uptake takes about 30 to 45 seconds to start tracking it. But eventually they're both going up. I don't know which way is the right way to do this. They're both going up together. So that's what you want to see, and that's 10 mils per watt. But what happens sometimes is the work rate continues to go up, but the oxygen uptake plateaus or changes its slope. That change in slope is actually very important. It means that there's something going wrong either with the stroke volume or the AV difference, or both. And so that's actually really important to be able to dissect out. But just looking at the actual software where they've constrained those slopes is actually very important. And that's part of the reason, again, to pull it up on your workstation and see where they picked. Not only either the computer or the technician or both have done something with it, and see if you actually agree with it.
Okay, last question to save everybody's time, and again, we are not going to win from the amount of questions, and this is very good. Please send in all your questions, because we can capture them if you write them down in our questions and answer box. So please do this. So then we go for the last question. I pick one. What is there a difference between VO2 slope or the equivalent of oxygen? And you can ask the same question for the equivalent for CO2 or VO2 slope.
Yes.
Why do you need them both, or what is your comment on this?
Well, it's a mathematical issue, and we can actually get back to that, but it depends on whether the slope goes through the origin or not, or whether it's actually a little above or below the origin. But in general, the VE/VCO2 slope and the ventilatory equivalent are very similar at the anaerobic threshold, within probably one of each other. But it just depends. Again, we can get back to this if you want to. I can show you a little figure that shows why, if it goes through the origin, they're basically identical. If it doesn't go through the origin, then that's what causes the offset.
Okay, now, thank you. I see a lot of very interesting questions in front of me. So it's even hard for me to stop this very interactive, nice part, of course, of this. But I'm looking forward to our third webinar. Thank you, Professor Stringer, for this, again, excellent presentation, answering the question, try to be as clear as possible. And I would thank all the participants, again, attending and staying with us even till now. But I even hope, and I encourage you to attend the third meeting even more, because this interactive is very important. But I know, or I think we cover the questions also from the first practical session, and now the interpretation, and everything comes together. And we tried really to schedule 90 minutes. So looking forward to this. Thank you all. And I have to close it here.
Yeah, thank
And
you.
see
Have
you.
a good day. Bye-bye.
Bye.